Hello and welcome to OffBlueMedical. Today we will discuss more high-yield topics regarding quality improvement and patient safety for the USMLE. So the first topic is medical errors. So medical errors cause tens of thousands of unnecessary deaths annually in the United States. So the classification for medical errors, we have active errors, which means an immediate error. An example of this would be a surgeon operating on the wrong leg. A latent error is going to be an accident waiting to happen. An example for this is a patient rooms without adequate camera quality to monitor breathing. Preventable errors are basically preventable. So an example would be a patient with a known penicillin allergy who's mistakenly given amoxicillin and develops an allergic reaction. A non-preventable error, from its name, we know that it's not preventable. So a patient receiving a correct dose of chemotherapy but still develops severe neutropenia despite standard precautions, this is a non-preventable error. And a near-miss event, an example for it would be a nurse preparing to give the wrong medications, but the pharmacist notices the discrepancy during verification and corrects it before administration. So regarding medical errors, there's the Swiss cheese model. This, and I've put a picture here from Wikipedia, it says the Swiss cheese model of accident causation. This basically means that we have a system where we have put barriers up. So sometimes errors are going to line up and cause the error. So the risk factors are going to line up and there's going to be an error made. So right here, this is going to be an error. So it says the Swiss cheese model of accident causation illustrates that although many layers of defense lie between hazards and accidents, there are flaws in each layer that, if they align, they can allow the accident to occur. So in this diagram, 3 hazard vectors are stopped by the defenses, but one passes through where the holes are lined up. So let's say this is going to be a medical accident where a patient receives a wrong dose or a severely high dose of an opioid and it leads to death. So these are the errors that are in the system which lined up and they caused the accident. So there are multiple layers of defense and the errors occur when the holes align. So there are many risk factors of medical errors. There is patient risk factors and there's physician risk factors. So patient factors include extremes of age, complex condition, prolonged hospital stay. The more you stay in the hospital, the more likely they will do a medical error. Poor health literacy, low socioeconomic status, communication barriers. For physician factors, inexperience, knowledge deficiency, fatigue, cognitive biases. And talking about cognitive biases, they are high yield for the USMLE. So to get started with the cognitive biases, I will discuss anchoring bias, which is very common. Basically, it's being excessively influenced by initial information, which biases the interpretation of subsequent information. The first impression is going to stick to your mind and you will stick with that diagnosis. So an example would be a patient with known osteoporosis presents with back pain. Here the clinician anchors to osteoporosis without ruling out serious causes like fractures or malignancy or spinal cord compression. The second one is going to be confirmation bias, where you selectively seek and interpret evidence to conform with your initial belief and you neglect the contradictory information. So a team emphasizing an elevated pro-BNP supporting congestive heart failure diagnosis while downplaying persistent cough, shortness of breath or infiltrates that don't clear with diuresis. Availability bias is basically choosing diagnoses because they are readily available. So an example would be a clinician who recently missed a pulmonary embolism diagnosis now overestimates the PE risk in similar patients and overly orders CT angiography despite a low disease probability. A premature closure, this one is easy from its name, it's just premature closure. So it's arriving at a diagnosis too early without considering other differential diagnoses. An example would be immediate ordering of IV furosemide based on preliminary chest radiograph impression of pulmonary vascular congestion without considering any other alternative diagnoses. So framing effect is the order or way initial information is presented, biases interpretation of subsequent information. So an example would be initial radiograph reading frames the diagnosis as pulmonary vascular congestion, preventing the consideration of a primary pulmonary disease. Other cognitive biases for the USMLE include affect heuristic, which is the physician's action swayed by emotional reactions rather than rational deliberation about risks and benefits. This one is a little bit hard, but an example would make it easier. So favorable emotions toward the patient lead to less rigorous evaluation, and negative emotions could lead to excessive testing. This is basically the affect heuristic. Overconfidence bias, being overly confident in yourself, this is overconfidence bias. I've wrote the definition and example on overconfidence bias, which is the attending physician dismissing junior residents' legitimate concerns about alternative diagnoses. Base rate neglect is ignoring underlying incident rates of conditions or population-based knowledge. An example for this would be positive exercise stress test in a young woman prompting angiogram. Though base rate of the disease is severely low, is so low the result is more likely a false positive. Commission bias is the tendency to act. Omission bias is the tendency not to act. So commission bias is the tendency to act. Example would be unnecessary diagnostic testing. Omission bias is the tendency not to act when it is needed. So example would be failure to initiate urgent airway management or ACLS due to uncertainty about the diagnosis. One last cognitive bias is going to be the diagnostic momentum. So mistaken diagnoses passed from one clinician to another without validity being questioned. So the label is going to stick to patients. An example would be a diagnosis made on initial presentation becomes subsequently or increasingly definite with time as each subsequent clinician reinforces it without reassessment. High reliability organizations have 5 core principles. These are organizations, let's say, an example of a high reliability organization would be a hospital that operates under serious conditions, but they have less than average event rates. So let's say there's this hospital where all other hospitals have, let's say, 10 patients that have adverse events. This hospital has 2 or 1. So they are called a high reliability organization. So they have 5 core principles that they follow to become a high reliability organization. So the first one would be preoccupation with failure. So their mindset is focused on detecting potential failures before they occur. They treat near misses as opportunities for system improvement rather than a proof of effective safeguard. So they report good catches and they also report adverse events. So they are equally important here. Reluctance to simplify. They avoid oversimplification which may mask critical issues, and they understand that systems may fail in unprecedented ways. They are also sensitive to operations. They maintain constant awareness of their care delivery processes among leaders and staff, and they are committed to resilience. They quickly bounce back after errors and after unexpected events, and they prepare teams to respond to these unexpected events, and they have deference to expertise, and they value insights from staff, and they break down the hierarchical barriers to ensure that the best ideas rise to top. So these principles are important. You should be familiar with these at least. Preoccupation with failure and reluctance to simplify, sensitivity to operations, commitment to resilience, and deference to expertise. So the foundational, high reliability organization practices for implementation include leader rounding. Basically, this is senior leadership proactively engaging with frontline staff on safety concerns. So clinical application would be administrators round on units to identify barriers to safety and resource needs. You should be familiar with this term at least. Visual management systems is information displayed openly for all to see and understand operational status, such as infection rates, safety metrics, and others. Safety forums would be structured meetings for multidisciplinary teams to discuss safety systems systematically. So they may have monthly meetings to discuss these or address sentinel events. Sentinel events are serious adverse events. Let's say severe temporary harm to a patient. This is called a sentinel event. And they also might discuss system vulnerabilities. Safety huddles are brief meetings. Safety huddles are brief meetings, brief daily team discussions about risks and concerns. So they may have morning huddles discussing staffing, patient acuity, equipment issues, and recent incidents. So after adverse events, how should we disclose this to the patients? And should we do this or should we not do this? So you should always disclose any adverse event you have to the patient as soon as reasonably possible after discovering the adverse event. And you should state clearly that an adverse event or medical error occurred and describe the facts as you know them. Don't speculate about causes or implications. An example would be, I am so sorry this happened to you. Let me find out why. And you should be compassionate, acknowledge the emotional impact it has on the patient and the family, and assure the patient and the family that you will investigate what happened. So per the AMA Code of Ethics, the American Medical Association Code of Ethics, they say that the physician is ethically required to inform patient of all facts necessary to ensure understanding of what occurred. So errors don't necessarily imply negligent or unethical behavior, but failure to disclose may. Moving on to procedural complications, we have most procedures, surgical procedures, are associated with complications that may occur. We will take the most high yield ones and discuss them, and just be familiar with these. So paracentesis complications would be bowel perforation, bladder perforation, bleeding, infection, hepatic rupture or puncture, splenic puncture, hypotension. Thoracentesis complications, most important and high yield one, is going to be pneumothorax. So this is the most common complication. The historical rates were high, but they were reduced with ultrasound guidance and operator expertise. They are caused by visceral pleural puncture, allowing air entry. Also, hemothorax, costal nerve injury, vessel injury, from the placement being too high in the intercostal space, causing intercostal bleeding and nerve damage. And if there is low placement, it may lead to diaphragmatic injury. Central venous line complications include arterial puncture, hemothorax, pneumothorax, brachial plexus injury, venous thrombosis, air embolism, infection, bacteremia, malpositioned catheter, and cardiac perforation. Arterial line complications include arterial puncture, bleeding, thrombosis, ischemia, gangrene, infection and local abscess, and compartment syndrome. Lumbar puncture complications include, the first one is going to be the most high yield one for the USMLE. It's post-dural puncture headache. This is the most common. It occurs from CSF leakage through the dural puncture. So it's positional. When the patient lies down, their headache gets better. When they sit or when they are upright, their headache is going to get worse. But when they lie down, it's going to get better. This is called the post-dural puncture headache. It occurs 1 to 2 days after the procedure. It's managed with bed rest, hydration, caffeine, or an epidural blood patch, and the epidural blood patch is going to be the correct answer on the USMLE. You might also have bleeding and spinal hematomas, traumatic tab causing blood to come out, and spinal cord injury, nerve root injury, meningitis, and herniation risk, which is important. Lumbar puncture is contraindicated in increased ICP, increased intracranial pressure, because it could cause herniation, such as tonsillar or transtentorial herniation. So general prevention to avoid these procedural complications would be to use the ultrasound. It dramatically reduces pneumothorax risk from thoracentesis and lowers the central venous line complications. Expertise, practice, and you should always practice. Proper anatomic landmark identification. Sterile technique prevents infection, bacteremia, empyema. Monitoring for complications such as post-procedure imaging, vital signs, and symptom assessment. Human factors engineering. This is basically you design systems based on the fact that humans are imperfect and errors are predictable. Errors are going to be inevitable, so they will occur. There's no system where errors don't occur, they always occur. So forcing functions is high yield. Its design features that physically or logically prevent an undesired action or require specific prerequisite action first. So before I get into the healthcare example, I'm going to take an example in the automotive industry. In cars, you cannot shift into reverse without depressing the brake pedal. So you put your leg on the brake pedal and you push it, and then you can shift into reverse. Without that, you cannot accidentally shift into reverse. So the healthcare example would be removal of concentrated potassium from general ward stock prevents accidental IV potassium overdose. So this was an early forcing function identified in healthcare. They don't rely on human memory, basically. So they are inherently safer because the error just becomes impossible. We have error analysis tools, the most important of which is going to be the first one and the third one. So the first one is the failure mode and effects analysis. It's prospective, so you try to detect errors before they occur. So it's prospective in the future. Prospective analysis, identifying potential failures before they occur. You examine each process step and prevent errors by identifying and redesigning the high-risk failure modes, and you use it before you implement new systems or protocols to catch design flaws. I'm going to discuss the third one before I go to the second one. The third one is going to be the root cause analysis, which is a systemic investigation of why an adverse event occurred. It's retrospective, so an accident already occurred. Now we are going to investigate why it occurred systematically. So it's retrospective. Failure mode and effects analysis was in the future, prospective. Root cause analysis is going to be retrospective. So you use the 5 whys technique. You keep asking why this happened. This distinguishes active failures and individual errors from latent failures, which is going to be system problems. You dig deep into the systemic root cause to prevent the recurrence. You address the system problems. You don't blame individuals here. Morbidity and mortality review is a retrospective case-based review of adverse outcomes. So the method is going to be a multidisciplinary team discussing cases. They focus on the system. They don't blame individuals. They identify and contribute factors and generate quality improvement recommendations. So they are protected under peer review privilege in most states. They build a culture of safety. You should remember that failure modes and effects analysis is forward. Failure modes is forward, so it's prospective. The root cause analysis is retrospective, looking in the past. One other high-yield topic for the USMLE is going to be the closed-loop communication, which is a process of acknowledging the receipt of information and clarifying with the sender that the intended information was received. It confirms understanding and cross-checks information for accuracy. So the sender sends a message, then the receiver repeats it, and the sender verifies accuracy. So an example in healthcare would be a physician saying, give X drug 0.2 milligrams intramuscular now. The nurse doesn't just say, okay, I'm giving it now. That's wrong. The nurse is going to say, I'll get X drug. They are going to repeat what the physician said. I'll get X drug, 0.2 milligrams intramuscular, to give immediately. And then they'll say, I'm giving X drug, 0.2 milligrams intramuscularly. The physician is then going to say, correct, give it, or correct, give 0.2 milligrams intramuscularly of X drug. So this prevents errors from miscommunication and ensures medication accuracy and dosage verification and team coordination.